My name is Zsolt Garami. I'm the medical director for the Vascular Ultrasound lab here in Houston Methodist. Today we're going to review Ultrasound and Bubbles. I want you to join me on the web with any questions on the website pollev.com and just enter DeBakey and send your questions. Or on your phone, type in DeBakey and to the text 37607. Please ask questions. You have to keep me awake. I'm going to fall asleep on my own talk. If there's no questions, my lecture is going to be a little short today. So please, after this lovely advertisement, I want to show you my first slide, which is the advertisement for our master class. Please join us on June 11 for the first TCD master class. We divided, my mouse is too big, I need to chase my cat here. So what I wanted to advertise for is, we were listening to your feedback and you guys wanted more TCD talks on our Vascular Ultrasound Master Class last year. So we are dividing our master class to TCD carotid for June, and the rest of the Vascular Ultrasound will be back in November. So 6 months apart, we'll do 2 master classes. This will be June 11, and I'm extremely happy to report that the website is up and running, and we have international speakers lined up. So this is our program. We might have some changes in our program, but we'll go through our protocols and interpretation. We'll have speakers from the Netherlands, from Portugal, Croatia, Hungary, and I think the most interesting one is the future of the TCD for Dr. Pinton. And the afternoon we'll have hands-on on real cases, real patients, so not just volunteers. Sorry about my big mouse again. So today, what I would like to talk to you about the TCD and how the TCD recognizing any bubbles in the circulation. So this is your M mode TCD image, and what you see here is a red signal from 30 to all the way to 55 millimeter depth, which is your right MCA. Your left MCA, I'm sorry, is not in the picture. The right ACA is from 60 to 70. That's your blue signal. And the midline is about 75 millimeters. And you have the contralateral left ACA, which is red. So basically, if you're colorblind, just give up TCD right now. You really need to differentiate these colors. And again, what the presence of the M mode shows you, there's a flow in that area with intercepted by the ultrasound probe. These signals are reflected with 2 megahertz single crystal probe reflecting from red blood cells. These are the motion, this is why we call it an M mode screen, and all the reflection what you see is coming from red blood cells. If anything else travels in the system, you will able to see some white lines. But again, first DDR, depth, direction, and resistance. So continuous means low resistance. You have a good diastolic flow here. Depth is again by millimeter, and direction, red is towards you, blue is going away, and you cannot invert it here. So just get used to this screen because you're gonna see it a lot today, even you're watching me live or reviewing this recording. And this is how a single bubble looks like in the system, and this is probably just the air bubble traveling from the terminal ICA to the middle cerebral artery throughout. So means that it's entered at the proximal MCA and goes out all the way. So did not go to any M2 branches, didn't go to any perforators. You can see that it goes all the way to the cortex and has a time scale. So when you look at it, takes time to go from the proximal MCA to the distal, and this is why you have this forward slash kind of direction. And this is very important that it can be a straight line. So you can see like 1, 2, 3, 4 different segments while it's traveling. And again, the speed, if it's in that signal, is running here somewhere around 20 centimeter per second, right in the middle of the diastole. Here is the end diastole. You see an ACA, which is traveling similar speed, has a backslash because again, it's getting further away from your probe. So these are the signals that we will talk about today. So these are bubbles. These high intensity transient signals or microembol signals, these are the similar names, and this is, for example, traveling in the vertebral, going away, traveling through the basilar. And it's very interesting that you see when I'm getting in the vertebral basilar, there's a little slower slope. So because it's at the end of the diastole. When it jumps to the basilar, look at the slope becomes a little sharp, means that maybe it's jumped over the systole, and this is why it's traveling faster. So a slow slope, if you want to ski here, that is more easy. And this is like straight shot throughout the basilar, similar 2 centimeter distance, 2 centimeter distance, definitely different speed. And again, this is my favorite slide from Dr. Moring, who created this M mode, and this is from his original publication, not the dolphin. This is just what you see in Houston. So when you go for fishing, then you see some dolphins. The cows, those are the artifacts. So this is how easy to differentiate a real embolus, which is moving, swimming, rather than a cow who is not supposed to be there. And again, those are just sitting on the zero line when you just tap the probe or you move the jaw, some muscle movement, creating that. And what you need to see is that it's multiple depth, same time. So that's why it's a straight line. So it's not traveling. Not traveling, zero speed. This is why it's sitting on a zero line on the spectrum. So this spectrogram is always coming from where the yellow line, the depth, is recognized. So out of the 33 MO channels, we are recording just one. You only listen to that one channel when you hear the spectrum and on those bubbly sounds. And you're going to hear some bubbly sounds. These are some new screens from my new machine. Again, the same M mode is coming from a Spencer machine, but these are just new colors. And what you see is a resistance difference. So you see a low resistance versus a high resistance flow, but there is less diastolic flow here. And again, by the PI value is going to help you to differentiate that. So when the PI is high, then you know that these are high resistance vessel, continuous, really nice. These are the middle cerebral artery, again with a low PI. So the PI values again between 0.6 1.1 will be your normal values. When those are getting higher, you will see it with chronic hypertension and increased ICP quite often. The billing codes are going to help me to really divide what we're going to talk about today. We're going to talk about the PFO, the TCD bubble test, which is a CPT code 93893. This is emboli detection with contrast injection. That's the CPT code, and it's just my short abbreviation for that. The difference between, again, the 92 and the 93 is the contrast. So while you do an emboli detection, you don't inject any saline, and this is where you just put a head frame on and you are spontaneously recording emboli. If we have time, we'll go talk about emboli detection today as well, but today we're going to focus on my PFO CPT code. Usually you can combine that with the diagnostic TCD, so we wouldn't start just with the PFO because you really would like to see the intracranial circulation first, and then you do the bubble study as your second study. And why we like our bubble study so much, and I think this is where we are kind of fighting with our cardiology friends, that while you're looking at this picture of the 2D echoes, these are basically 2D pictures. So 2D pictures captures right there when it's my screen. If my hand is behind the screen, you have no clue how many fingers I'm showing. And this is where the 2D image, the bubble need to cross your 2D image to be able to see that. So if you have a really few bubbles, this is why the echo is not picking those up. Why the TCD is monitoring a 3D flow volume with all that sample, what you can see usually like 9 millimeters, and your vessel is 3 millimeters or maybe just 2 millimeters. So you definitely over detecting all the 3D flow, what you have in the middle cerebral artery. So this is where we see that one of the advantage of having 2D versus a 3D view of your flow. And the second one is you will see some examples when we do Valsalva. You don't see anything on echo. So this is where the Valsalva becomes very, very important, how we were provoking these right to left shunts to open up if they are not open all the time. So again, gold standard is TEE. The TEE is again what we would like to do as a confirmatory test, but for screening, transthoracic echo with bubbles or TCD would be a first level of screening, and it's so much easier to perform. You don't need to swallow anything. Just need to sit there and have an injection into your arm, and we're going to show it to you in a moment. So how we started to see, and this is actually one of those incidental findings, that a patient with a PFO, after PFO closure, reported that they have less headaches, and this is where the PFO and headache connection came in, but also PFO with tiny clots traveling through them, not to the lung, but to the brain, may responsible for TIA and stroke symptoms, and we put them in a nice, beautiful cryptogenic stroke criteria. So PFO was responsible probably 20-30% of those strokes, especially young people when you don't have large vessel disease. So this is why we are testing them. And again, we have a bunch of different treatment options, and this is why it's worth investigating these. One of my favorite paper, actually, the late Dr. Spencer, who also created this M-mode for us, that he showed that why he was using his M-mode. His transcranial Doppler with the bubbles, they were showing better sensitivity and specificity than the TEEs. So basically what he tried to show is when you have an image, the spectrum, here you only see like 5 or 6 bubbles. But to adding to that, you see about 40-50% more bubbles. So the M mode will be the gold standard now, how we are looking at bubbles and how we are counting them. Again, you can have your cardiologist criteria of 8-10 cardiac cycle. For our international consensus, we are having a total count of 30 seconds of total emboli count. And here's how we do the test. I would like to thank for my patient who graciously allowed me to videotape this lecture.
And we are getting ready to start.
And the camera was with the husband, so special thanks to my cameraman as well. For a moment, I'm just going to stop here because I want to show you what I'm using. So I have a special Self-T Intima butterfly. It's a 20 gauge with a Y configuration, because I can pull out the needle, and with a Y configuration I can connect to my stopcock. And I think it's very important that you have like a same protocol, and again I have a same supply for the last 20 years, and this is what of my accuracy on the protocol that we'll talk about each different pieces, but very important, I'm using the same needle, anticubital, 10 cc syringes, saline. And again, you can put this together. You don't need to have your own IV starting kit. This is a little bit cheaper when you just buy individually all these parts. So I'm going to connect now the two 10 cc syringes to agitate them and get ready. But in the meantime, in the background, you already hear the TCD is running on the patient head, doing a spontaneous embolus detection. Here's I'm ready for starting an IV. In the background, it's already running the sound. And here I am just cleaning the skin, a little bit of alcohol pad. Sorry about the blue box, they're supposed to just cover the face. And this is an uncut video from here. So I'm starting an IV, pull out the needle, and immediately see that the blood is coming back. That is one of the first important part. So right now, you guys did not see me touching the skin. I only hold the butterfly, and right now I'm covering with a tourniquet. So I was almost call it like a non-touch technique for how I'm starting an IV. But the second important that you see the blood coming back, that is one of the most important part to avoid the false negative studies that you're thinking that you're injecting and you have no clue what you're injecting to. So this is where you are 100% sure you have blood coming back, and this is where I'm seeing that I'm going to remove this from that end, and this is where I'm going to connect my stopcock, and I'm going to flush it and pull back a little bit of blood. You will see that I'm going to make my saline a little bit pinky, almost matching my butterfly color. And this is where you see the flush, and immediately just making my saline a little bit of pinky. And one of the other idea that I want you to watch that I'm agitating about 10 times, again, just on the physics. So here's my bottles. The bubble always goes to the surface. So if I'm injecting downwards, my bubble is going to stay last. So this is why it's very important that my injection needs to point upwards. So when you are pointing upwards, that you definitely will flush in your bubbles, and then you follow with a saline flush. Okay, so here comes the video. Agitated about 10 times. Beautiful bubbles.
Okay, now zoom out, please.
We already practiced how to do Valsalva. Injection is in. Asking to lift the arm up. Blue, 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 blue. In the background, you guys already hear the bubbles, and you see it on the screen. So this was like less than 3 seconds. You had bubbles in, and we haven't done Valsalva. So the reason I didn't do Valsalva, because I wanted to give the bubbles a chance to go to the right atrium. If you do the Valsalva and you inject during Valsalva, that would prevent your venous return. So that's why I am waiting about 3-4 seconds. Make sure the injection is in, and I'm getting an information. I'm getting the information that without any Valsalva, I have a shower already. That is telling me I don't need 2 injections, I only need 1 injection. My single injection shows the both results. My result is with and without Valsalva on 1 injection. So right now what you see on the screen, I didn't do any Valsalva. It's a positive study with the shower. Now I'm going to ask to do this Valsalva.
Hold it, bear down, push, 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 push.
And the Valsalva needs to be 5-6 seconds, and you see the waveform is changed. And it's released, and a Valsalva release bring you more bubbles. And patient could experience lightheadedness, so this is why this depth of the Valsalva is really goes down to 0. You quickly ask them to release. You don't want them to pass out on you. Another assurance is you put something on the back of the patient, so make sure they don't fall backwards. So I'll have a comfy chair or put them back on the wall. And this is where we would repeat the Valsalva a few times. Make sure the air clears out from the circulation. This is another one. I will go back to that one. I just wanted to emphasize one more thing. After we finished, when I'm taking out the needle, I will make sure one more time that I have blood in it. So that is another confirmation indeed that you saw my injection was about 2-3 seconds. So it's extremely fast. So this is why I cannot do it in a hand, because cannot handle high pressure. So it needs to be the antecubital fossa. And what I did is, again, lifting the arm up, and at the end, I'm asking not to bend the arm, because if you bend the arm, this is when you are not putting any pressure on it, and you will get nice bruises. So if you see the patient next day and they don't have bruises, then you know that you're good with your needles and everything. But keep the arm straight and keep the pressure on it for 3 minutes, and that will prevent any bruising and stuff. So here's my next favorite slide of showing, this is actually 2 fellows. We're working with Dr. Alexandrov, and they were testing on each other with a different body position how many bubbles you see. So it's about 2-3 minutes difference between these 4 body position. You see that while you're laying down, you don't have too many bubbles. While you're laying down on the right side, a little bit of more. Bending over to the right. This is why bending over is never a good idea. But when you're just simply sitting, you look at the difference. While you're sitting, you have a shout of emboli. Hard to believe that this is a difference between these 2 studies, just the body position. So suddenly the body position is extremely important, and I guess one of the reasons why we like to do the echoes while the patient is laying down, and you're not going to see too many of those bubbles. Here you go. Second, when you have a patient having a TE done, the patient laying down on the left side. That's another funny position, because definitely we're looking for a right to left shunt. And you can say that, yeah, the heart is with a different angle, it's okay. But again, we're looking for right to left shunt. So the bubbles not going to go to the left. They will stay on the right more. So you really need to force them with the Valsalva to really open up that connection, I guess. So our protocol is in the sitting position, and in the sitting position you can do the best Valsalva. I think this is what we are practicing when we're going to the bathroom, and I think that's the other way of telling the patient if the Valsalva meter is not really showing how the velocity needs to go down. If the velocity is not changing, the patient is blowing the air out. So again, my maneuver to really understand how to do the Valsalva during my TCD bubble test. Please take a deep breath in, hold it, bear down, think about that you're constipated for a month and ready to go to the bathroom and delivering twins at the same time, and you're pushing a huge wine cask with your belly. So these are the three motions without any production will produce a nice big purple red head. Hopefully the eyes not bulging out too much, and this is where you need to see the fact that Valsalva needs to show up on my TCD. And this is how it's to show. Yes, here you go. So when you see that Valsalva effect, that you don't need any Valsalva meter, because even if you have a Valsalva meter with a 40 mercury millimeter pressure, that means your glottis is already open. Yes, you have a tube and you are keeping the pressure on, but that pressure, keeping the pressure in that Valsalva meter, already letting some air out. So you want to avoid that air going out, and this way, deep breath in, hold it, and you bear down, and then you see the velocity going down. So you need to see at least about 20% difference, and when it's compensated and comes back with the hyperemia, you see now is like 126% of your baseline. Another very important, just a personal and really useful practical trick is your time. So when you're injecting, you're watching the TCD time and you're injecting at 0,0. So when a seconds is 0,0, it's really easy to count up to 30 seconds, which is the total emboli count, to give you the 30 seconds total count of your embolization. So this is where, again, the total emboli count comes in. Again, some patient says we don't have temporal bone windows. Then we came up with this great idea with some Italian colleagues already published that I'm practicing on my own neck, a vertebral window. So you can monitor, basically the head frame is upside down and I'm monitoring my vertebral artery. Here you can monitor the submandibular ICA, or my friend Branko in Zagreb doing it with just the duplex. So the duplex alone able to show you terminal the ICA, and that's the same feeling that you're going to see. ICA is going to show your bubbles. So here is the ICA, the blue signal going away, and the bubbles on a second probe is in the MCA. So this is a red MCA, this is a blue is the ICA, and what you see is the difference to get from your neck to the brain. It's less than like half a second. I hope you like it. Still no questions. Guys, I really need questions because I'm gonna fall asleep soon. Please text DeBakey to the number 37607. Or go to the website pollev.com and just text DeBakey, and please ask any question. So here what you see is the terminal cervical ICA to the MCA. This is how long did it take to get the bubbles up to the brain. But what the bubble goes up, the bubble needs to come down. So this is the submandibular probe is catching that blue going up, red is coming down. The red signal is your IJ. So again, this is going into the submandibular ICA, and you see that signal behind it. That red signal is coming towards you, and this is your IJ. So almost like you can almost calculate how long does it take from the neck to the brain, and then how long does it take through the capillary system and the cerebral circulation to come out. So this is pretty cool that you see a bubble coming from the neck to the ICA, going to the MCA, and coming out from your IJ. This whole thing is less than 2 seconds. So these are 1 second. So this whole screen inside the yellow box is 2 seconds. So the other went from the the cervical internal carotid, but did go to the ACA. This is why it's blue. If it goes to the MCA, it's red. If it goes to the ACA, it's blue. And it didn't come out as fast. It's maybe looking at something here and there. It's not as obvious with that signal. Probably it's a little bit smaller as well. Traveling slower. So when a slope is not as steep, so you see that this is slow, this is fast. Difference? Traveling in systole, traveling in diastole. Cool? So you see that this is your zero line. In the spectrum is barely above the zero line, traveling with 10 centimeter per second. Here, this is in the systole peak, traveling like 50 centimeter per second. So these are the cool differences. There's so much more information what you see on the speed, more information about the bubbles. Yeah, it's a positive bubble study. In a moment you see any of those white lines, but kind of cool to see a little bit more details. What is your ultrasound is kind of telling you. And if you talk this Doppler language, the Doppler language, and you understand what the ultrasound is telling you, you're good. So here's one more. I just want you to have a feeling about the sound. Just listen to it one more time. Bubble, bubble, bubble. And I really like to do it a bilateral monitoring, because if you have bilateral monitoring, you don't need to double the unilateral side. So some people doing unilateral detection, but if you have one or two and you miss it, then those will be again another false negative studies. So when you do bilateral, you again doubling your chances to even catching those one or two bubble. Here's another good Valsalva. So before the Valsalva, I already have a shower. And the little Valsalva was enough to open up a second shower. And this is where we kind of call it almost like curtain, when the entire screen is just white out. But again, the sharp, nice sound, it's impossible to miss it. This is why it's important to have your sound. So TCD, luckily, it's recording sound. Don't try that on your duplex machine, because a duplex is not going to record the sound for you. So that's another big shower. So there's no question, you can count how many of yours, but the machine cannot count because just the whole thing is just shower. So we are predicting that this is definitely more than 300 or 400. We are not even counting. So why we're trying to count is because we had two grading systems. What is the international consensus grading system from '99? This has had to be a little bit adjusted because they were in Italy and they said grade 0, grade 1 is 0. So this is where I would say grade 0 is the 0. So in a publication they just probably shifted, or they made a mistake to grade it differently. But I think what they meant is grade 1 is 1 to 20, grade 2 is more than 20, and grade 3 would be a shower, or more about the curtain. The shower kind of moved to this area. And Dr. Spencer wanted to divide it into multiple groups. The reason for that, because they noticed that with their cardiologist friends, that if it's less than 30, they cannot through a wire through the PFO, and they cannot close them. So you need to have about 30 of these bubbles to really able to close those PFOs. So there's a line here that these grade 1 and 2 is most likely you won't able to close, while you run grade 3, 4, 5, you will be able to close with percutaneous closure devices. So this is my fancy scoring system. We're just going to call it Z-score for today. Negative, no hits. Grade 1 is when it's positive, you have 1 to 30. Grade 2 is more than 30. So we don't need that many criteria, because again, it's enough to know it's positive, and it's enough to know if it's less than 30 or more than 30. That is my two positive criteria. And my neurologist colleague, Dr. Volpe, convinced me that we should not withhold our criteria of 65 and younger. Previously, that was a cutoff for testing for PFOs. And we just learned that, again, as we are getting older, we want to get tested too, but also our patients, maybe while we're getting older, there's remodeling, resizing of the heart. They may have some other changes that may see PFO in older people too. I wanted to tell you more about the bubbles. So these are my bubbles, and these are my collections. And what happened is that one day we will see a case report why we thought that the bubbles also very important for this part of the protocol. Oh, I have a question. Can you detect bubbles in other vascular areas other than the heart? Oh my God, very good question. At the end, I will come back. I need to show you a slide or two. Indeed, if you pay attention to your carotid ultrasound studies and you decrease the gain, increase your sample gate, you're able to see bubbles shortly after the cardiac echo. When COVID started, we started to pay attention that we started to see microembolus signal on a venous study. So on a venous waveform, if we decrease the gain, we also started to see the same tiny white signals, and I'm able to show you one or two. So thank you for your question, because that is a very good question. I will show you. But why I think there's a physics pathway there too, that one of my physicist friend told me that the 2 megahertz, when your lower side is be able to detect better bubbles. When you have a duplex 5, 7, suddenly those are not ideal for microembolus detection. So again, something with the physics. So this is why my 2 megahertz probably the best way to detect it. So back to the bubbles. I just want to show you there's a red label and a black label. Just remember that. So the red label, the warning not to use in newborn. Why? Because in the saline, they put a little bit of alcohol in it. You're not going to get drunk, but there is a tiny milligram of benzyl alcohol. And believe it or not, this is what probably stabilizing my bubbles. Believe me. Here's the 2 different saline, white, gorgeous bubbles. This one, no bubbles at all. And when you stop agitating, it's absolutely dissolved in a second and you have a 1 cc air. This one takes a little bit. If you add a little bit of blood to that, that will be genius. So this is where, here's your black label, not much. Again, this is 2 minutes apart, same patient. With a red label, not to use on newborn, you have almost like a shower. So again, we did this testing just on 16 patients, and again, half of them had 2 or more category changes. So when you're talking about negative become positive, that is scary. But also when you're jumping categories more than 2 or 3, that's very important. So these are the category changes we saw. And again, not just like having 1 or 2 more bubbles, but these are category changes on those both scales. So when you go through these, again, the injection site, my saline, and if I have the camera for a second, zooming on my left hand, this is where my bubbles are, and this is again a 20 cc. These are my favorite ones. Second favorite is when it's a 10 cc, because you might need a second injection and you can use that from your 20 cc, but you cannot do it with a 10 cc. And the absolute worst that I do not recommend to do a TCD bubble or not even an echo bubble is the black labels. And the worst is your preloaded syringe. This is the most expensive and the worst. So the bubbles, what this is producing, that doesn't exist. So it's automatically just comes back together to an air bubble. And again, you see in the syringe why the air is upwards. So this is why you want to definitely inject upwards, not downwards when you're injecting into the patient arm. So these are my fancy bubbles. And again, the syringe, make sure it's locked. And again, Valsalva IV. So if you don't have a short extension, you have a long extension, think about that also wasting bubbles and wasting injection time. Recording time, remember the 0-0. So when I injected at 0-0, then you know 30 seconds. Documentation wise, 1 injection, you can do with and without Valsalva. Billing code, you guys already know, and make a beautiful report, because I think the TCD is definitely beating the echo any time and any day to detect the right to left shunts. We're unable to detect the left to right, but the right to left, we are unbeatable. I'm not going to talk about the therapy, but I'm going to show you one case. This is probably about 15, at least 10 years ago. A patient just picked up this chopstick for her kiddo, sorry. And luckily, when she developed the symptoms, the headache, and being nauseated, the husband, being a paramedic, immediately called 911. They had, again, CT done. They had everything done as showing negative, negative, negative. But we had a TEE. And this is defined as negative. Here's your septum. And what I want you to remember how gray this is. This is not white at all. And you don't see nothing crossing. TCD was positive. So this is where you need to convince somebody to, again, there's two tests. One is positive, one is negative. And how we settled it, that we went back to the transthoracic echo with the TCD monitoring together. So we did a same settings, a transthoracic and a TCD. And I'm going to, can you blind my video for a second? Can you take off my, thank you. So, okay, we can come back. What I'm showing here is a transthoracic echo showing you when you do a Valsalva, it disappears. So you really don't see the heart. When you're releasing the Valsalva, then you see the bubbles arriving. So this is, I think, one of the shortcomings for the echo. But again, we had the same time a TCD monitoring and catching those emboli as well. And what you see here, again, a repeat, so much white, and you see the bubble crossing. So this is your positive TE now with our special bubble. So this is where, again, the original TEE was as a little bit of gray, not as white, did not cross. Maybe the Valsalva was strong enough. So those are the differences, again, how you do the protocol. And again, you can do the TCD the same time. You will save bubbles. You will save IV access because you can do the TCD the same time. One of the pitfalls we have to admit is your pulmonary AVMs. So here's a big AVM, it just showers for 2 minutes, and we think this is right to left shunt. No. And this is my other pitfall that I wanted to teach you today. So I see a unilateral signal. So, sorry, one more time. Let me go back for a second. I stopped it the wrong time. So I want to stop it somewhere here. So what I see, I don't see anything on one side. I see a beautiful Valsalva, and I see something on the other side, but extremely I'm extremely suspicious that these are not MCAs because I did not hear the blah, 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 blah. I heard some little noise, red and blue, and the flow is really low. So this resembles like a venous signal. And this is where I see a red, blue, almost like a Valsalva, and release of the Valsalva. So this is like a venous bubbles, and this is why it's unilateral. This is why you're not seeing it on the other side. So the other side, if it's a true PFO, the heart as a central, pump it on this both sides. So you should see the bubbles on both sides. You see it on unilaterally. And what the confirmation was, we put the duplex on it, and we see the bubbles going towards the head. So the head is here, and during the Valsalva, you see the IJ letting the bubbles cross. I just think that this is freaking amazing when you see those bubbles going towards the head. So this is one of the pitfalls that you need to be aware when you see something on your screen and said, hey, it's only unilateral. I don't see it on the other side. Doesn't sound like a true MCA bubbles. So call it IgA reflux. And here's my other beautiful pitfall. So this is a young individual, and the bubbles on this side delayed with 1 heartbeat. And you see the bubbles are a little bit less, the waveform less. So this is actually behind an IC occlusion. So this is how long does it take to get from one ICA to get to the other side, cross and get into the left MCA. So this is again, this bubble delayed in the left MCA is because you have a left IC occlusion and the bubble crossing. So delay, that's again another suspicious good pitfall for my TCD. And here's another pitfall. Again, you don't see anything on one side. On left side, I see the bubbles, one single embolus. So that is one bubble. So it's a positive study with the IgA reflux. So I wanted to talk more about the good and the bad bubbles. So I guess today I'm going to finish up. And can you take off my screen for a moment? I'm going to finish up with these PFOs, but because of this request, I really want to show you guys where do we see some bubbles. And please ask questions. So if someone else is still with me, please send us more questions. I really wanted to thank for that question, and I wanted to show you some really cool pictures. I hope you guys gonna like this one. Okay, can you go back on my screen? So what's this? So for me, this is stunning that this is again a pseudo waveform. So this is the neck of the pseudo aneurysm, and here is a tiny microembolic signal, a tiny clot. So you are picking it up. What does it tell you? It goes towards the neck. What does it tell you again? It's not coming from, it's maybe going into the PSA. So it's maybe those are the really fun directions that we need to figure out. If this is negative, maybe it's coming out or going into the PSA. And my second beautiful example, this is a lag venous duplex right femoral vein. This is a bubble. Cool. So thank you for that question. And again, another thing that's very interesting, that this is again an IJ, and this is captured during our vasospasm protocol in NICU. So what you see here, that you have your submandibular ICA for a submandibular Lindegard ratio calculation. And when you are injecting any medication through a central line, this is the danger of the bubbles, that the TCD will catch it for you. So please use those filters, the 28 micron IV filters. They hopefully get rid of these air bubbles, or let your injection rest a little bit. That will also get rid of the bubbles. And our best so far is maybe hit it with your scissor, hit it with some metal. That's how the microcavitation will be get rid of faster, and then you can flush out the remaining air bubbles. So take off my screen again, sorry. I just want to finish it with my, yes, can we go back to my slides? I just want to invite you again for the TCD Masterclass. What I can promise you, the registration is so cheap. When it's free, I think it's affordable. It's going to be live streamed. If you would like to have the hands-on piece, sadly you have to register and you have to pay minimal fee for your CME. I have one more. Can these bubbles impact oxygen levels? No, but the oxygen level can impact the bubbles. The example for that, if you have a patient with a prostatic heart valve, and a prostatic heart valve with the metals generate cavitations, and that cavitations is producing more than 3 bubbles per minute, may produce TIAs, may produce some symptoms. So what we'd like to do is administer oxygen and count if your bubbles number is going down. Because if you put 100% oxygen, just 5 liters for 10 minutes, you will see tremendous decrease of these bubbles. In the last case report I think we prepared and ready to submit, we counted about 20 without oxygen and became 2 in 10 minutes interval. So what we did, you establish a baseline before you do the oxygen inhalation. You do the 10 minutes with oxygen, and then you remove the oxygen and go back to really go back to the no oxygen level, truly confirm that really did the oxygen made a difference in this monitoring. So thank you for the second question as well. Let's finish up and just please go visit our website, the TCD Master Class, up and going. Join us and see you in June 11 in the Houston Methodist Hospital. Thank you guys and have a great day.